Good evening, everybody. So today we are going to hear about palliative care in renal diseases, and we have two speakers: Dr. Suresh Sankar, who is the senior vice president of clinical affairs at Nephro Plus, and is a senior nephrologist at VS Hospitals, Sundar Medical Foundation, and former chief medical officer at David Kidney Care. He has dual specialty and with general medicine as well as uh, nephrology from American Board of Medical Specialties and Internal Medicine. And he he's a patient-centered practitioner, and that knowledge that he has gained from the uh, various aspects and we want to put into practice in the patients so that they get good of patients. And he's a team leader with expertise in design and executing consistent quality improvement. And he has a lot of journal articles, review papers, and uh, chapters in few books, and this industries in clinical research, epidemiology, public health, and health system. Welcome, Dr. Suresh. And next, we have Dr. Anuja Damani, who is currently the associate professor at Department of Palliative and Palliative Medicine and Supportive Care at KMC Manipal, who has done her MD from uh, Tata Memorial Hospital, Mumbai. She is in charge of renal supportive care clinic at KMC as well as scientific committee in impact care. And she has membership in various professional organizations like RCPM, ASCO, and IAPC. She is a national trainer for elderly and palliative care with NHSRC and organizing team member for education in palliative care and end of life care. She's a reviewer for Indian Journal of Palliative Care, Cancer Research, Statistics and Treatment, and the Journal of Global Oncology. And she has won HBM award in 2017 and IDRPC award in 2018. And her interests are renal supportive care, cancer pain symptom and management, supportive care in oncology. So, Dr. Anuja, welcome. And Dr. Suresh, I think Dr. Anuja has to leave at 8 o'clock. So let's allow her to have her session first.
Hello.
Okay, Dr. with you?
Yeah, thank you. Can you hear me?
Yeah. Please go on, Dr. Anuja.
Right. Thank you for a warm welcome. Thank you for having me here. I'm going to share my screen. Just check if you can see it. Can you see the slides, sir?
Yes, ma'am. Yes. Ma'am, a little more louder would be good.
Okay, my internet connection is a bit unstable. In case you lose me anywhere, just let me know. I'm going to stop the video so that we are uninterrupted.
Sure, ma'am, sure.
All right. Okay, so welcome all. I'm going to talk about nepropalliative care from a perspective of palliative care. And of course, Dr. Suresh will be taking it ahead from a perspective of nephrologist. For this session, we are going to look at basics of understanding what CKD is. I'm not going to go in depth of it. I'm just giving you an overview. And why we need nepropalliative care, how we should approach kidney supportive care, how do we prognosticate, and ultimately, what are the end-of-life care decision-making challenges. So just to walk through the basics, we all know the definition of chronic kidney disease, and we know that screening is done by EGFR, urine analysis, looking at USG and of course, screening for complications as well. So anything GFR less than 60 would be CKD for more than 3 months. Okay. And I'll be talking more in context of end-stage kidney disease here. So when we look at this shows how do we guide, how do we actually guide the kidney failure, and how do we monitor kidney failure according to guidelines. So coming to pathophysiology, we all know that there are a lot of factors which lead to CKD. So initiating factors do cause effect on kidneys, decreasing the number of nephrons, causing a lot of inflammatory reaction in the body, causing structural changes, increasing the intraglomerular capillary pressure, causing more sclerosis of nephrons and further depletion. So basically, this becomes a vicious cycle and reduces the number of nephrons, which practically becomes not reversible. And CKD affects a lot of organ systems, almost every organ system of the body. So that is why it's important to know what the basics are, because we are going to look at complications in these patients. As palliative care physicians, everybody should know basics of how complications occur in CKD. So it affects cardiothoracic system, and it affects the cardiovascular system. It affects the pulmonary, it affects the pulmonary hemostasis. It affects it causes a lot of metabolic changes. So we should know of what complications is CKD going to cause in a person. Now coming to management of CKD. So management, of course, first thing is to slow down the progression. As we saw in the pathophysiology, becomes a vicious and irreversible process. So slowing down progression is very important. So that's why we have to diagnose these patients early. We have to treat comorbidities better. We have to give protein restriction, and also look at any nephrotoxic drugs that will be causing damage to kidneys. And as primary or palliative care physician as well, you should know how to treat complications. So treatment of complications and slowing progression is the basic idea of management of CKD. And once the CKD level enters the end-stage kidney disease, that is grade, it is less than, so when we enter the end-stage kidney disease less than 30 GFR, we should look at managing the thing in 3 different ways. So when you look at comprehensive conservative care, that is for patients who have not opted for dialysis. Patients who opt for dialysis may get prolonged due to dialysis. So dialysis is not going to revert the process, and ultimately transplantation is the thing that can be done. But overall, we are looking at a prolonged process here. So why do we need palliative care in these patients? So when we look at the data given by Global Atlas on Palliative Care, renal failure was related to 1% mortality. So this is a global data. So 1% of population is a huge number. And it is the 16th most common cause of death right now. And by the year 2040, the way comorbidities and the other chronic illnesses are increasing in numbers, it is going to become the 5th most common cause of death, right, by the year 2040. So we are on the verge of a big need for palliative care in nephrology setting. So, of course, advanced kidney disease is not asymptomatic, and there are potential complications of dialysis as well. So longer the patient is on dialysis, the patient is going to develop complications eventually. And clinicians often assume a more favorable prognosis. So when we prognosticate these patients, we have to be very careful how we prognosticate. We have to use right indicators for prognosis. We have to use right scales for prognosticating. And it is important to prognosticate to anticipate complications and anticipate survival in case of chronic kidney disease. And usually clinicians are over optimistic in prognosticating. And dialysis may not always form a cure, right? Dialysis is going to be a palliative treatment, which is prolonged palliation in a form. So when we look at the data here, we are seeing three main components of care of chronic kidney disease patients. We are looking at preventive treatments, we are looking at managing the CKD, and we are looking at supportive care. So when we look at the part here, that is middle income setting. So low income and low middle income settings, usually the supportive care component is extremely poor. And in lower middle income, again, patients who are receiving dialysis are also few. So when we look at this, there is huge burden of ESRD or ESKD, and the patients who are on renal replacement therapies are extremely less as compared to the overall burden. So lot of patients who are others in the other three colors, that is red, yellow, and blue, are going to need more aggressive supportive care measures, who are probably not able to access the renal replacement therapy or who are not recognized, because these patients will be more symptomatic, right? So with that background of CKD, now we are looking at how we'll integrate palliative care in management of CKD. So basically, founding principles of palliative care, we all know about it. That is dignity and respect. First, comforting a patient, providing optimal quality of life, and to treat dying process as with more humaneness, and also after death, supporting the families. So during the process as well as after death, we have to support the families as well. So this figure here shows how an integrated approach can be adopted for care of these patients. So we have to integrate palliative care early, that is adopt early as possible, and to be there with the patient throughout the journey, with, of course, inputs to treat symptom, to make decisions. And there are various triggers for referral of palliative care, referral to palliative care, that will be coming across in next slides. And we have to blend the principles of palliative care with chronic kidney disease management. So it is going to be a lot of co-management rather than just managing symptoms. We are looking at managing the kidney disease as well as managing symptoms hand in hand to make life of these patients much easier. And of course, embed the palliative care approach into the usual care processes. So there should not be a distinction in palliative care and care of kidney disease patients. It has to be more integrated. So this is how we'll be able to provide a best possible quality of life to these patients. When we look at kidney supportive care, the basic things that are provided is symptom management, of course. Looking at total symptom burden and managing the total symptom burden. Palliative care, one of the aspects that cannot be denied at all is expert communication. So communicating prognosis, making decision-making process as more smoother with shared decision-making, and of course, advanced care planning, which is an important integral part of any chronic disease patient's journey. Palliative care would also, kidney supportive care or nephropalliative care would also have interdisciplinary team approach. So of course, the nephrologist is the primary doctor who is managing these patients. But along with that, there are gamut of other issues that need to be addressed by various team members. So we need a palliative care specialist, we need a nurse, we need a dietitian, social worker, or a rehab specialist. So there are a lot of other members who are part of team and who work together to optimize quality of life of these patients. And we have to give option of comprehensive conservative care, where dialysis we know is not going to improve quality of life, or patient chooses not to undergo dialysis because it's not going to provide much benefit to the patient. And of course, one of the important things is end of life care, which is exclusively a lot of patients in this group are basically dying in ICUs, dying in emergency rooms, or getting treated till the end. So we have to plan around end of life care and supportive care at end of life, and maximize dignity, maximize quality of life, and give a proper bereavement support to the family. So these are the domains that kidney supportive care would touch upon. Now, when we look at various symptoms of CKD, we look at different symptoms at different stages. So stage 5 and 5D, that is patients on dialysis and post-transplant patient, the most common symptoms are listed here. And with worsening condition, the patient's symptom burden would increase and the need for palliative and supportive care would increase. So these are the important symptoms which are listed here, which are distressing and bothersome for the patient. So we can see depression, cachexia, facial edema, loss of taste, nausea, vomiting, breathing difficulty, fluid overload, recurrent abdominal pain, itching, restless leg syndrome, and financial toxicity. So these are the things that you can look at, which are present in almost all the patients who will have who are CKD patients. And during dialysis, there are certain symptoms that would increase. So this will cause a lot of distress, especially cramps are the ones which we very commonly come across in dialysis wards. So having muscle cramps, headaches, chest pain, nausea, vomiting. So these are some of the symptoms that we must address as a part of kidney supportive care services. So as we know, we have discussed that it is a multidisciplinary approach, and there are various tools available to screen these patients. So there are various symptom assessment tools. IPOS renal, ESAS are the most common ones that are used. Functional assessment tools like KPS. KPS is one of the validated tools in functional assessment of these patients. Other aspects like exploring their understanding regarding the treatment process, the prognosis, and the treatment outcomes becomes extremely important for proper decision making. Nutritional assessment of these patients, knowing how we can improve quality of life. So we need to assess the baseline quality of life of these patients to understand what else we can do to improve quality of life. And of course, psychosocial assessment is extremely important. Depression is one of the most common symptoms, or one of the most common conditions which is associated with CKD patients or any chronic illness patients. So we have to actively screen for mental health issues. We have to look for various support systems that can be generated for these patients, giving a proper care to the caregivers as well, assessing the financial situation, coming up with a lot of support systems in those aspects, and handling the practical challenges. Along with that, planning the entire course of sickness, advanced directives, documentation of surrogate, which is very important, that if patient is not able to take decisions at end of life for himself or herself, then there has to be somebody else who is actually taking the decisions for this patient. And that has to be done much in advance rather than waiting for the dying process to set in and then identifying the surrogates. And of course, providing optimal end of life care. So there are certain prognostic models. So all prognostic models that are proposed, no prognostic model for prognosticating the survival of these patients is foolproof. So some of the indicators that are markers of poor prognosis are elderly age group patients, diabetics, the ones with poor EGFR, and of course gender. So these are some of the prognostic indicators that can be used. So there is no good quality evidence, but we can prognosticate using these indicators. One of the most important prognostic indicator is the surprise question. So surprise question is basically physician asking himself that would I be surprised if this patient dies in next 12 months? So if the answer to this question is no, then probably that is one of the best prognostic markers or prognostic indicators that we should be initiating discussions about advanced care planning and advanced directives with these patients. Others are anything KPS, so Karnofsky's performance scale less than 50. That is more of bedbound patients. Then Bunsen score is one of the important prognostic tool that can be used. And these are some other prognostic tools that can be used. So coming to the last part of this presentation, that is when the patient is on dialysis, how do we work around the decision making? So how do we initiate a process of talking about withdrawal of dialysis? Of course, we saw withholding of dialysis is something that you don't begin the dialysis, give an option of conservative kidney care for this patient. But when we talk about withdrawal, that patient has already been on dialysis for years, and now we are trying to understand which patients we should choose to withdraw from dialysis. So it's important to understand these recommendations. So patients who have decision-making capacity and who are fully informed and they make voluntary choices to withdraw from dialysis, after knowing the pros and cons of their decision-making. So here we can consider withdrawal from dialysis. Of course, this is a shared decision-making process, but we have to give choice to the patient. So patient autonomy is one of the indicators. And if the patient has previously asked for refusal of dialysis. So when advanced care plan has already been documented and patient is asking that I don't want dialysis anymore. Or if there is a surrogate who is appointed and who refuses dialysis, which is in best interest of patient, then we can consider removing patient from dialysis. And if this patient has some irreversible neurological impairment, or these patients have or the continuity of aggressive invasive care is futile, then we can consider removing this patient from dialysis. And last, one of the indicators is when this patient is getting more harm than benefit from the dialysis procedure. So these are some of the indicators. Do we have time, Dr. Sunil? Can we go through the case?
No problem. Sunil, how have you planned the time? Because I mean.
Yeah, we can take. Yeah, Anuja, you can go. You can have the spaces.
So
Mine will be 30 minutes, Anuja. So that's fine.
Okay,
It's not till 8:30. No, we are only 7:25. You can go ahead.
right. So for this case, I would want everybody to just focus upon issues that you can identify as a palliative care physician for this particular patient. So now we saw what would palliative care do. We saw what are the challenges with CKD patients. So Mrs. Grace is an 89-year-old female who is a known case of diabetes and hypertension since 30 years. And she is also a case of ischemic heart disease. Now, since 6 months, she has her CKD has progressed, and she's had an episode of acute kidney injury as well. And she's a widow, and her husband has expired 8 years back. Primary caregiver is her daughter, who takes care of her with help of housemate of a house help. And finances for her are taken care of by her children. And there's no health insurance. 1 year back, she's been very active and able to do her daily activities. And now her physical condition has declined and she's not able to do any basic care for herself. Last 2 weeks, she has lost interest in activities and is bedbound, and she's increased pedal edema and decreased appetite with nausea. So when we look at her labs, so these are her lab findings. Her creatinine has shot up, and these are other parameters that you can look at. So I would want you to tell me, I'm going to stop my screen share for a while, and I think everybody can see participant screens now. I want you to tell me about this patient. What are the concerns as palliative care physician that you would recognize in this particular patient? So you can
Just unmute and speak.
you
Yeah,
can
I can
divide it in terms of physical concerns, psychological concerns, social concerns, and any other concerns. And how would you proceed with decision making, and what would be your inputs? So you can answer in chat, or you can just unmute and answer. That is also fine. I see one answer as old age from Prakhar. So Prakhar, can you just unmute and tell me what do you, why do you emphasize old age, and what is your input? What is the importance of age in this particular patient and decision making?
Yeah, she is 89 years of age and dependent on her daughter for finances. She is very, for the last 2 weeks, she has lost all interest in works and normal hobbies which she was having. She's also a known case of IHD.
Yes.
So, comorbidity is also an issue. Finances is an issue with her. She is depressed and having a creatinine of 8.1.
Right. So let me just put a question to our nephrologist here, nephrology expert. Sir, would you offer dialysis to this particular patient, and how would you consider other factors in your decision making about dialysis in your setting?
I mean, and to the audience, I think, I mean, from what she's already spoken,
Yes.
this is clearly not a black and white situation at all. Just because she has advanced kidney disease, you couldn't, right away start dialysis. The countering forces are, I think.
So we would consider that she is elderly with multiple comorbidities.
So the age and morbidities will counter. Then there is then of course her psychological status, which is quite evident. And the third thing is, of course, there's a stretched family situation with regards to support and the financial implications. And I think we'll also talk during my talk, what if you put it in motion, what do we know? I think that's the wisdom that nephrologists know, and that is where the truthful conversation should happen, saying that if we go, what lies beyond that, so that the patient and the family is better informed about the decision making. And what happens in the real world is that they might take it up for a short-term goal kind of a situation. And sometimes there's a lot of emotional coaxing into giving it a time-limited trial. That's what happens in the real world in the Indian context. A few of them, a minority few may opt out of it. If they're very strong, financially very stretched, then it becomes a choice-limited therapy when they won't step into it. I think that's how it plays out.
Right. Thank you, sir. I see Sangeeta's answers. Sangeeta has put up some of the important points here, that there are psychological issues and there are social issues that we need to consider as a palliative care physician. And of course, we've seen spiritual issues and financial concerns. So you as a palliative care physician would assess this patient more holistically, looking at all the issues that you can identify. Here I see a component of low mood. I see a component of psychological distress. I see a component of social challenges I see that she has been a regular church goer and now she is not able to do her routine prayers. So there are those issues, and of course financial in our setting is one of the most important aspect that we should be looking at, because this is going to be a chronic process. So right, so Prakhar has also put some thing like one patient used to organize money and do it intermittently. So I think Dr. Suresh will be able to highlight this point about how do we use intermittent dialysis during the course of in the end stage kidney disease patients for symptom management. So yeah, right. Thank you, Prakhar and Sangeeta, for answering. But I would want people to think about these patients and think about how we can integrate principles of palliative care into management of CKD patients. So I think my time is beyond time, 2 minutes. So I would just stop here and over to Dr. Suresh and Dr. Sunil for further.
Thanks, Dr. Anuja. And maybe we can take a few questions as you need to leave at 8 p.m. And then Dr. Suresh can take over. Are there any questions for Dr. Anuja?
I think, Anuja, if just for the benefit of the audience, maybe good to share a few lines on the learning experience from renal supportive care from your division, because I think you guys are truly, ahead of the curve.
Right. So
What has been your learning in our cultural context? How are decisions made, and a lot of other changes also happening on payment of kidney care.
in the real world scenario, in our context, I think one of the important approach, one of the important things that we must remember is we are approaching this patient as a team. And when the nephrologist would actually, so what we do in our setup is it's not possible to, see each and every patient of undergoing dialysis every time. So what we do is we do screen in the dialysis units, and we use a symptom assessment tool like eCells for screening, and we do have a sort of very comprehensive assessment of patients who are on ongoing dialysis. So it may not be possible to actually manage all the patients at all the visits. So we would screen all the ongoing dialysis patients, and those who screen positive or on the distress scale and the symptom management, symptom assessment tool, we would focus more and keep a regular follow-up. So this process is something that can be done by even nurses or dialysis technicians in a dialysis ward. So those are patients on dialysis. And there are certain issues with patients who would opt for conservative kidney care. So if our nephrology teams come across these kind of patients who would not benefit from dialysis, who are not fit for dialysis, or who opt for conservative kidney care, or these patients are choice restricted. So these patients, of course, the palliative medicine is an integral part of management team. And we keep a very strong follow-up and build up support systems for these patients. So in real world scenario, with so much of burden of or patient load, we cannot just see every patient. Ideally, it should be every patient, but we do try to screen the patients and then see whoever we are supposed to see. So we would do physical assessment, we would do psychological assessment. We have a psychologist on our team. If we screen these patients positive on depressions, we use 2-point depression scores for screening of depression and mental health issues. We will analyze that, and we have social work and support systems available for social and financial support for these patients. So it is definitely going to be a teamwork if you're planning to integrate supportive care in patients who are undergoing dialysis or end-stage kidney disease patients. So that is how we work in our team.
Okay, thank you, Anuja. Anybody else has any questions? Then I think there will be more questions to Dr. Suresh. We'll take the issue. So, Anuja, thank you for this excellent presentation and informing us what really happens, what's happening in the setting where renal palliative care has integrated into the nephrology. Thank you. And Dr. Suresh, it's over to you.
So, am I audible?
Yes, yes.
Okay, good. So thanks, Pallium and of course the palliative care group for getting me into this learning curve, this part of my career, and I think it's excellent that we are going through these kind of conversations. I think it's good I'm coming after Anuja, so mine is going to be more simplified as nephrologists what we see, and I'll walk you through in the next 30 minutes or so a very simple view of the journey that we go through. I think fundamentally what we are seeing in India is the fact that the non-communicable diseases epidemic, with all the clustering of behavioral factors driving hypertension and diabetes, leading to a lot of cardiovascular diseases in terms of strokes and heart attacks, which we have seen over the last 10, 20 years. And kidney disease is now kind of entering the space. And kidney disease, if you look at it in terms of the magnitude of the problem of manifested kidney disease, is kind of hides behind diabetes, hypertension, and cardiovascular disease. But it's also important to remember from the topic that we are talking about, that when you're going to see kidney disease, you're very likely going to see a combination of the other diseases which carry their own morbidity. So this overlap is a key theme that we will see in our patients when we get into palliative care. And this is a very fundamental physiology that, a slide that I think you need to remember to understand the clinical dimensions. And this is also relevant to the symptoms that patients with kidney disease experience. I think a lot of you will know the kidney as an excretory organ in terms of when urea creatinine is the parameter to measure excretion. Two critical aspects that the kidney does outside that is what is called regulation of sodium and acid-base balance. Therefore, your fluid status, your electrolyte imbalance, and acid-base status are very critical for all cell functions. Therefore, kidney disease, when it has inadequate excretion, leads to dysregulation of all these components, which in turn has a profound effect on other organ functions. The third component that also has implications is what is called the synthetic function of the kidney. That is synthesis of activated vitamin D. So it is activation of vitamin D, which has influence on minerals and therefore the bones, and synthesis of erythropoietin that has anemia. From a symptom management, I think if you're facing a kidney disease patient who's got significant anemia, you'll be very surprised how much of symptom improvement happens when you just correct anemia, even though you don't, control the urea and creatinine. I think it's a largely undermined knowledge, so that I would emphasize to this group when it comes into symptom management. So keeping this in the backdrop, you have excretion, you have regulation of salt-water balance and acid-base balance, and the synthesis of blood and activation of vitamin D, synthesis of erythropoietin and activation of vitamin D. With that in the background, we'll kind of broadly step into the whole sphere of kidney diseases. As nephrologists, we always look at it as acute and chronic kidney disease. And I give you some rough numbers of the incidence of kidney disease, which in real life term is much less common than cardiovascular diseases or diabetes and hypertension, which is why you saw the small little circle within the larger aspects of other diseases. And this is what I think Anuja alluded to. When you look at chronic disease, I think the world has come to a kind of an alignment that with regards to the terminologies, that we go from stage 1 CKD to stage 5. And generally, kidney replacement of some sort is usually done in this range. And one important aspect to bear in mind is the indication to start chronic dialysis is still a mix of an art and a science. There is no precise number or a precise parameter based on which you need to start dialysis. Moving on to symptoms. As I told you, you can divide it in 3 ways. The symptoms pertaining to the urinary tract, which will most likely in more advanced disease, low output and therefore fluid retention, actually occurs only in a small proportion of patients. The larger proportion of symptoms are related to effect on other organ systems of the low kidney function. And it's typically the GI system predominates, the cardiovascular system predominates, the musculoskeletal and dermatological can occur in a small proportion of patients, and in extreme stages, neurological can happen. Now, you also need to bear in mind that symptoms can also occur related to the cause of the kidney problem. Diabetes, which is responsible for about 40% of chronic kidney disease in India, can cause symptoms of the neuropathy or peripheral vascular disease or eye complications and so on. So this is how you kind of tend to see what is within the urinary tract, which is actually very little. A lot of it is other organ systems and related to the cause. A very simplistic way of seeing. The other way of seeing is what occurs late, what occurs when there's moderate, and what occurs when there's early. If you kind of super add the stages of kidney disease, stage 1, 2, and 3 would just be here. It's only when it's stage 4 the symptoms start showing up beyond the body's compensatory ability. Bear in mind, one of the early symptoms, actually patients may come to you with actually nocturia and excess urine output in the night. That is due to inadequate urine concentration, and it's very counterintuitive that you have progressive kidney disease and actually have more urine. The anemia can show us up energy loss, and appetite and bone pain may start showing up when somebody is CKD 3 or 4. I think one important aspect that I would encourage all of you to do is, I think in practice context, always use any kind of app, MD Calc app, where you're able to take your creatinine and look at this patient's age and weight and gender, which goes into different kinds of GFR formulas, and convert that so you're able to kind of place the patients in one of the 3 different CKD stages. So this happens around CKD stage 3, 4, and as they go into 4, 5, then they start manifesting the whole bunch of symptoms that can happen. Bear in mind at this point that drug toxicities and particularly hypoglycemic risk are very significant factor that you need to keep in mind. The other logic is that if you have a diabetic patient who presents with hypoglycemia, make sure that you look at your kidney function, which is, I feel it is often missed in the real world. The drugs are adjusted, but the cause of the hypoglycemia is never ascertained, and it could be kidney disease in hiding. Having said that, in the early phase, the only way of picking up kidney disease is knowing who's at risk and then checking them for kidney disease. The The two most important tests are a urine for albuminuria and a serum creatinine. So then what happens? I think this was something that was mentioned already. The focus is on making sure the kidney disease progression can be delayed. In the current level of knowledge, we have certain drugs that come into this list, which is SGLT2 inhibitors and glycemic control, and a drug that prevents mineralocorticoids from excessive mineralocorticoid action or mineralocorticoid blockers. So that has come into play, and that is redefining CKD progression in a big way. I think that is a talk by itself from the nephrology perspective. Then, as we alluded to, the complications with regards to the anemia and the bone disease, I think this has a lot of drug interventions to work on. And of course, the other aspects of malnutrition and acidemia. The profound clinical symptoms, as I told you, happen from the comorbidity, and then comes the transition into renal replacement, preparation for renal replacement in the form of education, what choice one wants to make, and initiation in a planned manner. So this forms the framework of how a nephrologist approaches. And the first three is what happens in a kidney care clinic, and before they transition into dialysis was the right half. But having said that, I think there are a couple of things that you need to keep in mind. As somebody goes down the CKD stages due to progressive disease, other events that happen, particularly what would you say, a drug intake that is intentional or accidental, including non-steroidal or antibiotics or non-allopathic drugs, situations where they need to be hospitalized for a surgical procedure of some sort, or an infections that could be community or hospital acquired. These kinds of events will accelerate kidney disease progression and actually tip over them into a need for needing dialysis. So in the management of CKD, one of the core thing is to make sure that they don't get into a superadded acute kidney injury. What happens in terms of decision making and options? You have dialysis, which we call as artificial replacement, and you have transplants, which is placing another kidney into the body. You have to keep in mind that dialysis only provides 15% of kidney function at its best, whereas a transplanted kidney, you put a single kidney, and that in turn kind of hypertrophies and steps up its function. It provides 70% of normal kidney function. But most patients who, in terms of replacement option, will mostly go down the dialysis pathway. And hemodialysis is a lot more common, often offered option in the world. Peritoneal dialysis is a much smaller one. Very few go on to have a transplant, and even within that, most of them have a live, and deceased donors is a much smaller percentage. Then in live, related is the only both are within the legal purview of India, but this is very tightly regulated, so it still remains mostly live related option. The limited scope for a donor is what limits transplantation. Now, then, so I think we should spend a little bit of time as to what choices we offer with regards to hemo and peritoneal dialysis, since that is the most common form of therapy. What is better with hemodialysis is the fact that people feel that somebody else takes care of them, and the time interruption is only certain days of the week. What patients don't find it appealing is the fact that exposure to needles, the disruption of their life, the time to travel, the cost related to it, and so on and so forth. And the other part also is, since it's the intermittent nature of the treatment, the dietary restrictions tend to be a lot more rigid. Versus if somebody wants to do PD, it is a more continuous process. You don't need the machine. You can do it in your home. Your diet can actually be more liberal. But what patients find hard is the fact that it's a daily process. Infection risk is something that is marginally of more concern, though clinically not so. And of course, there is a long-term effect of a higher glucose exposure through your abdomen, which has implications on cardiovascular system and also weight gain. So the PD hemo debate goes on before a patient makes a choice. But I think what is important to look at it, dialysis in terms of survival is a slide that very often that we use in nephrology. This was actually from a paper back in the early 2000s where they looked at survival of dialysis compared to other solid organ malignancies. And it clearly shows that dialysis does much poorer than other cancers, and it's kind of better than the really bad ones, which I'm sure in the last, since this paper was published, these things have changed to some extent, but I don't think the ranking would have changed. And this, if you look at it in women, it kind of comes behind, it is better than, say, lung C and pancreatic C, but not as good as some of the other solid organ cancers. So it ranks up quite poorly in terms of survival. But having said that, I think it's important to know how we look at the survival chances of a patient. There are what are the medical patient-related factors, which is what I think Anuja showed in terms of how common these are. There are the modifiable factors, which includes what is a comorbidity that they have, sometimes the cause of the kidney disease, residual kidney function, whatever little kidney function there is in that patient influences survival. And this has a profound effect on PD. So in fact, PD has that little bit of advantage when it compares to hemo in the early phase of the choice. Hemodialysis, how dialysis is practiced in terms of care of the patient influences. And last but not the least are the non-medical factors, which includes socioeconomic distance compliance, which I think in the Indian context has a profound influence. So the comorbidity weightage, how well dialysis is done, and the non-medical factors weigh in heavily beyond age. Having said that, some of the specific ones, which we'll talk in the case that we're going to discuss in the next few minutes, are the dialysis-related factors. What every center focuses on very critically is how well they manage the anemia of dialysis patients, how well they take care of their dialysis access, particularly if it's a catheter, how we manage fluid during dialysis sessions. This influences while on dialysis. And of course, cardiac, neurological, and lung status, and more and more now, oncological issues influence dialysis survival. Sunil, could I know how many more minutes I have for the?
You can take maybe even 15, 20 minutes.
No, I wouldn't do that. I mean, do we have a case? Like, I remember the last time there was a case presentation by the.
No, we do not have a case presentation today.
Okay, fine. So because I have 2-3 cases that we can walk through.
Yeah.
So I think this is how we tend to think. We look at the age of the patient, then dialysis is something that we can influence, and then of course the comorbidity. I think this is what I wanted to highlight on one of the cases Dr. Anuja had presented. As you said, this elderly, frail lady with who had moved to a need of dialysis with all the comorbidity and of course other financial issues. But essentially, this was a paper that came back in 2009 that looked and asked the question, if you start old comorbid patients, and the comorbidity burden is showed on the right of the slide, large proportions with diabetes, heart failure, coronary disease, and cerebrovascular disease, and you started them on dialysis, what happens to them at 3 months, 6 months, 9 months? What proportion of them died? This is very striking. You can see that the proportion, the ones who die, goes from anywhere from 30%, halfway, 70%, and nearly about 75-80% by the time they're here. When you have 6 months, you're the half. But I think what is also very striking is how much of functional status decline happens. So the ones who have preserved functional status and alive is a very, very small proportion. So I think this is something that you need to bear in mind if you're asked the question, what can this treatment offer to somebody who's old, frail with comorbidity? And I think this is a question that I think in the real world, all of us are going to face more and more as the Indian age pyramid is changing, as the Indian chronic disease burden is rising, and you're going to have a lot of elderly, comorbid, functionally dependent patients with very little social support system, and all the burden is on individuals and families. But the only ray of hope is the fact that payment for dialysis is radically changing with regards to government insurance exponentially rising in recent years. So maybe the financial burden is coming up, but coming down because of public payer systems, but everything else is on the family. So I think this is a very, very striking side that I want all of you to keep in mind. Having said that, I'll walk you through 3 scenarios, which are all patients whom I took care of. So I think they are very embedded in my memory. This was something where a patient, he's still coming to my clinic, but I'll just say it, saying that, you know, this patient experience, I know about dialysis, I don't want to go through it again in a different context. This is somebody with the CKD and a cardiac burden. An elderly gentleman who was differently abled, lives with his son, but his daughter-in-law was a care provider all through. And of course, like 70–80% of the Indian families, there is an out-of-pocket health expenditure situation. But when I initially took care of him, he actually came with a severe LV dysfunction, a minor infection that had this AKI, an acute kidney injury that superadded on the CKD. And we had to start him on dialysis as an acute life-saving measures. And we did tell the family that it is possible that he may stabilize and may come off dialysis. And thankfully so, that he came off to a clinical level. His GFR stabilized at maybe around 15–20. And so we could get him off dialysis. But he's quite frail. I still recall he's only about 45 kilos. And he's dependent because of his differently able status. But both luck had its way that he could come off dialysis. But I think in the process, the patient and the family kind of got an experience of what dialysis was with regards to a dialysis catheter, a dialysis session, and you know what happens after dialysis, what is it, what it is, and then you know the cost of dialysis care. But the only important thing was he's hospitalized, so he didn't have the hassle of the travel and the indirect cost and so on. But we also said, though he came out of dialysis with the level of GFR, we did say there is down the line, maybe in 2 months, 6 months, definitely less than a year, there would be a need for long-term dialysis. And that required that we plan a dialysis access care. And 4 or 6 visits subsequently, the patient was very clear. I do not want dialysis. And, of course, the comorbidity of the cardiac issue was weighing down on his heart. And the daughter-in-law used to ask, what will happen, doctor? What happens? We know what dialysis is, but why can't we go ahead? And the symptom burden in his case was a lot related to the heart failure, which actually drug management helped him. In this patient, as I alluded to before, we focused very, very strongly on anemia management. So we were able to keep the hemoglobin better. Had some skin itching issues we were able to manage. And sleeplessness was initially there, but once anemia was treated, that settled down. Because of his limited functionality from his different able status, that was not an impact from the kidney disease. So actually, that was not weighing on the decision making. About A year has gone by since then. He continues to be on conservative care, and when the time comes, we will have to see how it's going to play out. But the patient is very clear, and the son is also aligned with his father's wishes. So we kind of are in a pause phase with regards to planning for dialysis care. Anybody has any questions on this case and the approach, and have you had any experience something similar? I'll pause before I go to the next case. So this is not what if I need dialysis. I have experienced, so I am making a very conscious decision knowing what it is. Anybody on the chat box?
So what is the outcome of these patients if they do not go for dialysis at all?
Well, like I said, in this case, right? So we anticipated in a 6-month phase. And so he's gone off to a 1 year plus. The outcome is if you manage your anemia well, if you manage your heart failure symptoms well, and luckily he doesn't get an acute injury, the CKD GFR can hang around there for maybe about 1 to 1.5 years, before which they will, less than 2 years, they'll flip over into a need for dialysis. And at that time, the acute complication will be cardiac. I think one other important thing, maybe pertinent to your question, is what complications or what is the terminal event that happens, right? CKD and dialysis patients die of cardiac causes, at least in anywhere from 40 to 60% of the cases. Some part of them will be a coronary event or heart failure. A large proportion of them will be sudden cardiac arrests. That's what happens. Some of them get into infections. That is another 30-40%. So only the other 20% will die of other reasons. It could be a bleed or a fall and a trauma, or so on and so forth. The time period, I would say, is less than 2 years, and these are the kind of terminal events. Let me see what's on the chat.
There are some questions.
Yeah, I'm just looking at this. So I'm seeing 802. And CKD, what level of hemoglobin should we go for blood transfusions? CKD anemia sometimes behaves like chronic anemia, which we'll see in other contexts. If you are having a comorbidity like this patient with cardiac issues, I would suggest you look at transfusions if he's symptomatic or your hemoglobin is hovering under 7. Now, if there are economic reasons, then you kind of stretch it to a 6, but that's kind of pushing your luck. There's another question. Many patients don't want to know because of economic reasons. How to explain to them the complications compassionately? I think this is one place. I mean, let me just touch upon the fact this economic reasons is changing significantly thanks to government programs. Having said that, if for economic reasons that they do not want to start and not be able to start, I think the foremost thing is to say that we still can do medical care and do symptom control for a multitude of issues, and also assure them if anything life-threatening is to happen. The kidney care team is always there to hospitalize him and ensure that the distress alleviating treatment can be done, and provide them options about it, which includes, oxygenation, IV diuretics, morphine, and beyond that, any sedation to alleviate distress, so that they feel they don't have this visualization that the end is going to be distressing from cardiorespiratory distress or any other symptom. So if there are no questions, let me go to the...
There are no more questions, not related to this patient, but
this is the one. Thank you, sir. Yeah, you're looking at the one, want to know regarding protein and potassium restrictions.
Yeah.
Okay, fine.
Protein intake in CKD patients with malnutrition.
Okay, fine. So I think I would say this is one of the most, it's like a boxing ring in the clinics with regards to protein restriction between patients, their caregivers, and the nephrologist often is a witness to it. So let me put it this way. I think protein restriction is relevant in the conversation, particularly in India with non-vegetarians, or if you're in North India. Because if you're in the South, and particularly if you're vegetarian, just by facts, your protein intake is already quite marginal, and a little bit of tweak, you're pretty much there in the CKD range. I think what I'm getting at is a South Indian vegetarian diet is pretty much a renal-friendly diet, but for the fact of the salt indulgence that may happen. So having said that, if you're non-vegetarian, I think we're learning more and more that plant-based diet, as you'll see in the literature, if you're running literature search, is beneficial because of the less protein load, the less acid load, the less phosphorus load, and actually that may be beneficial. So just shifting from less to a more vegetarian diet would be of help. With regards to quantum, we call it moderation of protein intake, and if you want to be mathematical, we call it 0.6 to 0.8 grams per kilogram. Now, I think it's very difficult for patients to know how to calculate all of this, and it's not necessary. But if you guide them that you don't know the common protein containing food, which are rich in protein, that is, if you're having a dal, or if you're having paneer, or if you're having any other kind of protein-rich food, that's what. Whereas there is protein-hidden food, which is like idli, dosa kind of thing. So those are quite easy. And I think, of course, how we cook vegetables at home with or without dal, I think these are the ones that influence. But having said that, patients always come back with choices. It's not about the protein, it's the addition of salt limitation and water intake. Though the question about protein intake, let me just deviate into water intake. Please do not insist that all CKD patients need limitation of water intake. It's not the case. It's not clinically necessary. We need water intake limitations if you have patients who have fluid retention, heart failure, where there's overt sodium retention. The rest of them, you could be more liberal than the 400 ml and the 600 ml, the 700 ml. One particular subset of CKD, which is ADPKD, restriction of water intake can be counterproductive and actually cause more rapid progression. If you have a patient with CKD due to autosomal dominant polycystic kidneys, water restriction can be counterproductive. In fact, you need to have more water intake. It's a different pathophysiological explanation. Maybe we won't take it on that right. So there is a question about, we are giving only twice a week dialysis to the patients due to less dialysis machines. Is this less effective than 3 times a week? Clinically, yes, but again, this is more an economic principle than medical, I feel, because if you're going to do 3 times a week, you're going to be disruptive of their time of the day, your staffing, and also working of the whole dialysis unit. I think this is the only way you're going to maintain equity of dialysis care. But having said that, twice weekly dialysis, we have learned, is not as bad as it is projected. It's better than what is ought to be thought of. The second important thing, if you're twice weekly dialysis too, if you're maintaining your hemoglobin well and patients have reasonable good fluid management and your dialysis unit is managing your fluid within sensible limits, patients actually do reasonably well. Diet advice for vegans. I mean, if the question is with regards to CKD, I think it's only kind of the kind of vegetables that you may need to use. Maybe, Sunil, if this question is send us an email, then we can share with them some very broad, simple advice with regards to which particular kind of vegetables they might want to restrict, more from the standpoint of electrolyte balance. And we always, again, look at the patient's blood parameters before we go into a broad brush saying restrict everything. And secondly, we also have to look at the patient's real life context and the choices that he makes. I think this broad brush, everybody does not eat everything. I'm not much of a believer. And I've applied that principle in practice, and you realize that patients can have more liberties than we think they should have. Having said that, let me move to the next case. This is another one that I encountered after COVID. It's actually, he was, what would you say, well endowed from the wealth perspective. So he was a North Indian businessman who lived in Chennai, who enjoyed his alcohol, but well cared for by his family. His liver had taken a toss from his habits, but he was not a decompensated liver. He just had he did not have manifested cirrhosis. But when he came to me, he came past a very long COVID, and he was needing oxygen at home, which he came off subsequently over the subsequent several weeks. But you can imagine between the COVID, the CLD, and also progressive CKD, he had significant weight loss. And given his elderly status, and I would say his weight was in the 50-55 kg, he was functionally independent. He would walk to the clinic. When his creatinine was 4.5, we said that you may need to look at the choice. We offered options with regards to dialysis. Obviously, he's not a transplant candidate. We offered the dialysis, and we went through about 5 to 8 sessions of conversations before we came to the fact that he came around and said, well, I'll have the fistula done. But it was late that the fistula was not mature enough to start dialysis. So we'll end up starting on a catheter, which we did. And we were able to transition him to using the fistula. But a few weeks after that, he started having low-grade fever, of course, a lot of diagnostic testing, and he went to one of the best corporate hospitals in the city. And they put him through an endoscopic ultrasound biopsy. Short and long of it, we picked up tuberculosis. So, and I'm sure that was activated because of the steroids he got from the COVID. And so before we realized, we had the whole clustering of morbidities, the CKD, the CLD, then now we have TB. And elderly people like these don't do very well on ATT, and he had a downslide within 4 weeks of starting ATT. And there was a big family huddle. His children came by him, and I would tell you that he was the happiest guy when everybody was around. He kind of knew that his health status was going down, but he didn't know that this was the last time that you're seeing all of them. And of course, as it is the harsh reality of the world these days, the children had to leave back in 2 weeks. And then a couple of weeks after that, his health status dwindled, and he came down with a catheter infection. So his fistula had a problem, so we had to reinsert a catheter, and he had a catheter infection. And we did have the conversation that, there's the multiple hits after starting dialysis. And we went over the fact that his long-term quality of life was poor. So the family, after certain hesitation, said, let's step up acute care, give it a shot. But I think they kind of reversed very quickly, and they said, we'll do symptom care, and we let them be by their bedside. And in a couple of days, he breathed his last. Now, what I think this case illustrates is the seesawing of decision-making. This is one of the odd ones where the financial part was not there. But as a renal care team, how we need to go through the oscillations, like from the patient's not wanting to the patient wanting. And of course, you'd start, there's what you say, the clinical twist of the tuberculosis, that worsening. And then, of course, then the decision making of, stepping back care and letting go. I think this case also highlights the convolutions of kidney cares and comorbidity. Questions around this case before we go to the last one? Sunil, we wind up by what, 8:25? What time do you want?
Yeah, 8:30.
Okay, fine. All right. So I'm telling stories of clinic in the hospital. So this is a very convoluted one. Speaks of age, comorbidity, and multiple morbidities. And here, I think the financial ain't there. The spiritual part, I think this is a North Indian Barbari family. They were quite bonded and they're very mature. And I felt they were and he was very, very balanced. He was very clear from a psychological perspective. Financial is fine. The symptom burden is multitude. And they're very rationalized at each point of time. They would weigh, they would discuss, and then come back and say, doctor, let's take a couple of days time. And then once we're getting into it, they were very clear about how to go through it, be it the TB diagnosis. But you kind of have to, we took them stepwise. And this was always, okay, let's go through this, let's see the next step, and then let's see. And then I think when the catheter infection happened, it was a big downslide. So this was stepping down. And I think what I felt in this, the cultural huddling of this kind of a background actually is a great cushion, and it has its own way of enduring that transition. I think that is one thing that we see, a very cohesively knit family which rallies around as a group actually was helpful. Sometimes such family situations can be disruptive, but this was a family that was very supportive to each other, and the decision was collective and they're very clear. Sometimes this can be chaotic. That's one thing I can tell you. If there are no questions, I'll move to the last case. This was somebody, an elderly lady, who was cared for by her son, who actually got to me from the oncology side. So you saw her cardiac, you saw a lung, and then now you see an oncology. Again, goes back to the theme, old comorbidity dialysis. This is the commonest one that we'll face. So this one was referred from oncology. She actually had a very large bladder tumor that was picked up very late during the COVID phase. And she came to us with an advanced creatinine level of 6 and very significant fluid overload. She was, we actually, as you hear the story, that she was nearly 25, 30 kilos above her regular weight, and she was bedbound, and the family was not aware of it at all. But we also knew that her creatinine was 1.4 just 2 months ago. So that tells a nephrologist that it's not a CKD, the kidney could bounce back. She, again, like our first case, came up with severe orthopnea. So we had to kind of get her on dialysis and work on her fluid management. And as I told you, the dialysis over 4 weeks, we got her body lighter by 20 kilos. And then we always had that thing in the background, right? That this kidney was functioning normally 8 weeks ago. So there is a scope for the kidney to recover. Can we make the kidney work and get the dialysis question off the table? But given her age and the bladder cancer situation and intermittent bleeding from the bladder tumor, the whole procedure of the biopsy was not feasible. So then you don't know what is the cause of the kidney disease. Was it a drug exposure and interstitial nephritis? We knew it was not a glomerulonephritis. But the biopsy not feasible, we said we did an empirical drug trial to see to make the kidney work. And then we didn't see improvement of the kidney. Then the patient came back and said, again, in this situation, From a financial aspect, it was an upper middle income family the son was caring for as a decision maker. And we had multiple discussions between the son, myself, and the patient. And they stayed very close by to the hospital. They said, doctor, we've had a go at trying to get the kidney back. Looks like there's a dialysis dependence is the fact. But then she also had this bladder tumor that was sitting that the oncologist said, they had not much to offer. So then we went over a discussion if dialysis is not going to be there, what the symptoms would be. And the son said that she would have her at home and we would watch for the symptoms, and then he would visit to take guidance, which is the decision that we took. This was dialysis started, withdraw from there, though she required further down, symptom management plan. And of course, this was the days with COVID in the background. So they said, doctor, can we do online, which we did a couple of times, where technology came to the fore. And then she stayed home for 3 weeks, and then she passed away in her sleep, and the son came and spoke to us. Now, this case is where, unlike the first one, where the kidney recovered and we withdrew, this was somebody who is on dialysis and consciously withdrew, though knowing that she could continue. And she didn't have any complications. She actually got better from the initial fluid overload. She got better, and then they consciously said, I don't want to go through with comorbidity. So I think when you're looking at kidney health issue management, what are the symptoms you should focus on? The focus is always, I think, do you have good blood pressure control so the patient doesn't go into heart failure and breathlessness? Your hemoglobin management is very critical. I can't emphasize it enough, how symptom-free the patient can be with good hemoglobin anemia management. Sodium in water can be variable. We're basically talking about fluid management here. I think that the core distressing thing will come from these three, the acute distressive issues. The bone and the skin can be distressing symptom burden, but not acutely sick. And then, of course, the rest of them can come from a whole host of comorbid conditions, which includes disturbed appetite, sleep, which can come from the kidney disease itself, and all the other, psychological impact from all of them together, and then the comorbid. I think those add on. I think you should have a framework of thinking which are the acute impact, which are the distressing, which are not acute impact, and think of comorbidity. And then that's the symptom burden that we need to focus on and work. Lastly, what I would like to emphasize is the fact that kidney disease, as it evolves, it's going to come with a significant comorbidity burden. And palliative care will become more and more reality because of the aging population that adds to the comorbidity. Choice restricted is very often practiced in India because of economic compulsions. But I think what is happening is, instead of not starting dialysis, the public insurance patients get started, they go for varying duration of time, and then it becomes a stretch because of indirect cost. Sunil, there's actually a very nice paper from Kerala, which came some years ago, that studied the non-direct costs of dialysis care. I should share that paper with you sometime. I feel this whole symptom management and nephrologist engagement in a more aggressive supportive care is going to be a learning curve there, where palliative care physicians and nephrologists need to do a fair bit of work. I think the nephrologists can be primary care providers, but I think they're going to need help to do it in a way that is more patient-friendly and that's more supportive of the caregivers. Let me stop there. I will stop the slide. We can take questions. Is there anything on the chat box? Sunil, remind me to send that paper on from Kerala. I think it's a very, very good paper that actually dwells on the Indian context of cost-burden.
Okay.
Because the insurance pays for the dialysis cost, but then there's a whole bunch of indirect costs that burdens families, and that that it quantifies it and brings it across very well. Any questions? So maybe if I can ask, just to get a flavor of the audience, Sunil, these are people who are trained in palliative care, and from where all from the country are they? That's something just to know where these people are.
All of them have done some basic course, at least some basic course in palliative care.
Yeah. No, but like, where are they from? The participants from where all around in the country are they from? Just.
Do we have some statistics?
Sir, actually, we have participants from every state, most of the states in the country. We have a group from CHAI, Catholic Health Association of India, around 29 doctors joining from CHAI. So they are actually serving the rural part of India.
Wow. Where are they located?
It's actually distributed among various states.
Amazing. So is that why I see they're all part of the CHAI? I can see Mary Lutz, I can see sister, and all of them are in rural.
Yes,
I think-
29 of
Okay.
them are from CHAI, and rest participants are not.
Okay. Since I think for them we need to look at kidney disease in a different perspective. One of the things that you see is what are called hotspots of kidney disease, which occur in several locations which are non-urban. There is places in Andhra Pradesh, there is some hotspots in Tamil Nadu, there are some hotspots in Maharashtra, which are non-urban, which are not lifestyle-related diseases. And there's a lot of debate about what is causing this. Is it excessive heat stress? Does it got to do with the job they are involved in? Because there is hypothesis, there is clustering among bricklin workers. In one part of the world, in Nicaragua, it is reported among sugarcane workers. So is it their job? The third thing, very often is labeled as a culprit, is a water source in these rural environments. And therefore, CKD burden in these kinds of environments are very high, and it typically hits rural males. But again, we don't have enough biopsy specimens to understand what exactly is going on in the kidneys. There's a variety of programs ongoing through academicians and also funded by ICMR to understand disease in this context. Why this CKD burden is high? So I think if you search it as a CKDU, because it's called CKD of unknown etiology, it's a very unique CKD problem in rural context. That's why. But I think if you want to manage the CKD in the rural context, I think it's about. I would also draw your attention to a very simple rural program done by Dr. M.K. Mani, who's a senior nephrologist in Chennai, who's in the retirement phase, where he's done screening and finding kidney disease early in rural contexts using very low-cost resources. That's pertinent for kidney disease as a problem in non-urban settings. Do you see questions?
I think Dr. Sangeeta wants to ask for
Portable dialysis
Dr.
at
Sangeeta,
home. Options for portable dialysis at home, right? Okay, so is it or Manish is? I think portable
that is very
dialysis.
many.
Yeah, you should. Sangeeta had a question. You want to take that?
Yes, sir.
Go ahead, Sangeeta.
Good evening, sir. Sir, actually, I'm serving in a district hospital. I'm a physician. Recently, sir, actually, I was having hypertension since last more than 12 years.
Okay.
And I was on telmisartan and amlodipine. I was taking myself. Earlier, I had gone for all the investigations. It was normal, sir. But since last 3-4 months, my BP was not getting control. So I had gone to gone for further investigations, and I even in the month of April I went to CMC Valor also, sir. There I was diagnosed as IgA nephropathy, they suspected, sir. But I didn't, actually I was scared and I didn't go for biopsy, sir. So, and looking at my reports and all, they have even suspected endocrine cause for hypertension. So they also started Finrenon, and the other medicines which is started for me is Telmisartan 40 mg BD, sir, and Clonidine 100 microgram TDS, Nifedipine 20 mg TDS, Dapagliflozin 5 mg they have started. And sir, with other medicines like iron tablets and other this Finrenon, and also total of
Not to interrupt you, I have put my mobile number on the chat box directly to you. This is Sangeeta Shubha, right?
yes sir, yes sir.
You see my mobile number on the chat box. I've sent it to you.
Yes, sir.
Just in the interest of other people in the audience, just call me or ping me after, right?
Okay, sir.
We can have a one-on-one conversation, right? I don't want to kind of go away from it, right? So I have put my number on the chat box to you. Okay. So
Okay.
just ping me on the WhatsApp. So whatever your questions are, I'll do my best to address. But at the surface of it, it appears that CMC has done a fairly, not fairly, I think an excellent drug management plan just from what you have listed. But maybe better if I listen to with regards to what your tests are and what your specific questions are. I'll assure you I'll do it. Just WhatsApp me and call me. Okay.
Okay, thanks.
Where are you placed, Sangeeta? Where do you play? I mean,
I'm from Sikkim, sir.
Sikkim, kind of got from
Yes,
here.
sir.
Can you see my number? Can you see my number?
Yes, sir. Yes, sir. I've noted down, sir.
Just note. That's my WhatsApp number too.
Okay, thanks, sir.
Anyway, put it on the Baroda group itself.
So the one question on portable dialysis at home.
Yeah. So portable dialysis as a technology has not come to India yet. I think that's very true. In the world, it's there in the very developed countries. It is quite a revolutionary technology that has made it more easier to use at home. And I don't see it coming to India in the near future, purely because of cost burden at a market level. Somebody at a very high level can I'm sure import it and do it with support from elsewhere. But I think nobody's going to do commercially because they can't structure the support system. But essentially, what it does is it recycles the what is called the dialysate that is used in the dialysis to again refurbish and use it again. So you don't need a big water treatment system. You just need a few bags of dialysis, and it kind of reuses it for dialysis care. And it's as big as a suitcase, so you can carry it around. It gives you a lot of travel options, and I think it's truly a revolutionary thing. But I think the other big difference in between the West and the here is where patients learn to cannulate themselves. I mean, so it's because of human resource is so expensive in developed countries. But in India, we still have somebody coming home and actually doing it, though you do it at home with a regular machine.
Okay.
Any other questions?
No. No more questions are there.
Okay.
So
thank you very much. Thank you very much.
Have to wind up, but I'm sure from your talk there are many points that everybody has. They got many points, and especially you talked about anemia correction, which can give a more quality of life, and some other points more. So
I think if I have to say 2-3 take homes, let me tell you only maybe 2-3. I think the anemia is one bit. Always don't underestimate it. 2 is please don't, from a quality of life perspective and also a clinical perspective, very strict water restriction is not necessary. 3rd is just from the flavor of it. If you have a South Indian vegetarian kind of a pattern, I don't think protein restrictions needs to be emphasized at all. The last but not the least, I have changed significantly is using home blood pressure monitoring, because with the home blood pressure monitoring, sometimes people go to the nearest clinic and get it done. That has tremendous value in protecting kidneys in the long term. I think those are very simple things that we have to keep in mind in kidney disease management.
Okay, thank you for this information and excellent presentation. Thank you everybody for joining us today. It's over to Rajesh.